and it's a blockbuster.
Right.
It's everybody wants it, right?
Right. Everyone.
It's a blockbuster. Yeah. So you have a blockbuster, and you have it such in high cost, and all of a sudden it's in shortage.
Which
so
is prohibitive.
So compounding is getting, and this is why a lot of I would say bad players are coming, and it's a mess. I agree with that. I agree that this is a challenge, but the answer is not to say don't touch it.
Right. That's the point we want to make.
The solution is to help people know, differentiate between good players and bad players. I mean, otherwise you deny them of the solution, and you make the solution even worse because you let the market define who's better and who's not. And you don't. I mean, me as a doctor, you have a leadership role. You have to help the patients, right? You don't just say, "Don't get near." It's not, and you just, this is no solution. You need to say, if you do need to use it, this is how to use it.
Right.
This is our role, because people will use it. People are using it. Even they estimating that 30% of people with obesity looking for GLP-1s are looking for compounded, are using compounded. If I had to use it, if I don't get consistent supply for the patient, and I do inform the patients that they have a choice, and they can get the compounded one, but I would only refer him to a source that comes from this 503B, and I'm sure this is a reliable source. I will not send him online on his own. And there are a few reliable sources, that 503B, that are very good. And are used by hospitals and everywhere. But I'm telling you, part of the fuss now, that is, you see it all on the news, compound medications, terrible. I can tell you, there are scores of medications that are compounded, they are not FDA approved, used by hospitals, and people don't make a fuss. Why? It's generic, and it is not a lot of money. But because of the GLP-1s, is backed by big pharma, that some of their worth is more than GDPs of countries. So of course, and a lot of doctors get their information from those pharmaceutical companies, because they control the agenda. But I can tell you, the same sources, the same 503B are giving your hospital lidocaine and adrenaline, and people and doctors are not even aware they're giving it to them, because the doctors. But now with GLP-1s, it's a big deal. I think it's a little bit double standard that we say don't use compounded if it's GLP-1s, but you can use compounded for adrenaline or for any other thing.
And welcome to the All Out Coach podcast. My name is Tim Mikhelishvili. I'm your host, CEO and co-founder of Amadev Pharma, a life science analytics agency that helps pharma and biotech companies improve their performance and productivity by measuring this patient and employee experience more directly and more objectively than ever attempted before. As you know, we continue to connect our educators, our leaders in healthcare and many different industries from one conversation to the next. And today we're going to talk about a topic that most likely will relate to you. If you live in the United States or anywhere else in the world, very, very universal topic of GLP agonists and weight management, with new options that everyone is excited about, that most of the population now qualifies for. And we have an expert in this field that we're going to hear from, joining us from Beverly Hills, California, Dr. Eldad Einav. Let me tell you a little bit more about him. He graduated from New York University School of Medicine, with postgraduate training in cardiovascular disease. He's a board-certified cardiologist, also in internal medicine at the Albert Einstein College of Medicine. He graduated with excellence from Hebrew University, Hadassah Medical School in Jerusalem as well. And over the past few years, Dr. Eldad Einav has been an active participant at Obesity Medical Association events, where he's a member. In fact, he contributes articles and answers questions pertaining to cardiovascular-related disease and obesity. In fact, what brought him to my attention was a recent article that he authored in Medscape that addressed the current shortage in obesity medications, which we spoke about previously with Dr. Angela Fitch as well on this podcast. In addition to his clinical work, Dr. Einav has authored peer-reviewed publications. He's won multiple awards for excellence in research, and he serves as clinical assistant professor at Upstate Medical University. Before establishing his current practice in Beverly Hills, he also served the community of Binghamton, New York, as a non-invasive cardiologist. And in 2016, he founded Cardiometabolic Medicine, which was later acquired by Ascension Lourdes. And Dr. Einav became the medical director of cardiometabolic health. And so since relocating to Beverly Hills, he's launched MyW8, which is a concierge medical practice dedicated to treating obesity with a heart-healthy approach. Welcome, Dr. Einav. Pleasure to have you here on the All Out Coach podcast. We're looking forward to learning more about your approaches and your success with weight management and obesity medications that are now available with some unprecedented efficacy as well. So first, welcome to the podcast.
Thank you for having me. Thank you very much.
So I'd like to ask you first how you started in the field of cardiology and focus on obesity and weight management. What inspired you to begin with?
So I'm very passionate about preventive cardiology, right? So from the beginning, which is metabolic disease related to cardiology and risk factors, lipid, high blood pressure, sugar control, all of the risk factors that contribute to cardiovascular disease. And then I saw that people have a lot of challenges losing weight, and I see in the charts, people are coming and the doctor just saying, "Oh, you need to lose weight. You have to lose weight because your health and your cardiac health is also in stake." So, but people cannot do it. So every time they come heavier and heavier and heavier, despite the recommendations that they get from their providers that, they really want them to get better. But so at this point I said, why don't I get more skills in this area and not just tell the patient lose weight, also guide him actively or handhold him through this process and help them actually lose the weight. And this is when I got more passionate about obesity, and I got board certified in obesity medicine and started going to obesity medical association and started to get more interested. And I saw that there is also a need for patients with cardiovascular disease to improve their weight, because weight is an independent risk factor. So not only through other risk factors like high blood pressure, like diabetes and high lipids, but also an independent risk for heart disease. Mm-hmm. And we can see also, so now eventually we have medications that can help you. When I started treating people with obesity, we didn't have the medications that specifically can show evidence of preventing heart attack and stroke. But now we do. And in the future, I'm sure there will be more agents and more medications, more interventions that could, other than, I would say, of course, other than bariatric surgery, of course, that's the only exclusion. But as a medical doctor, that I can offer medications and interventions that are non-surgical. We didn't used to have the tools, and now we're starting to have. And in the future, we're going to have more and more of these.
By the way, I had started my career at AstraZeneca as a doctor of pharmacy, working with obesity, not only obesity, but with cholesterol lowering medications. My obesity treatment experience came with rimonabant at Sanofi Aventis before AstraZeneca, but I spent quite an extensive amount of time working with and learning from cardiologists, non-invasive and invasive cardiologists as well. And what tremendous advances have I been and have we all been able to see over the last few decades. Why should cardiologists focus and specialize more on obesity? What is really the connection between obesity and cardiology?
Yes, so I am actually targeting weight as well, because I think a lot of the mechanisms of disease and risk in cardiology stem from weight. So, and I totally agree with the notion that treat obesity first. Yes, yes, you can treat blood pressure, but all of them are, can be improved with weight reduction, right? So even some of the lipid disorders, not all, can be improved with weight reduction. Definitely, glucose metabolism and diabetes and prediabetes can be improved. Even endothelial dysfunction, inflammation can be improved. So all of them, if you treat weight first, you can see downstream benefits that are contributing to cardiovascular disease, and also direct, as I said, independent risk for cardiovascular disease. So now we know that if we treat obesity, we can prevent heart attack and stroke with the right medications, of course. You can improve heart failure symptoms in some subset of heart failure disease, and also we can improve atrial fibrillation, improve results of treatments for atrial fibrillation. We can also improve obstructive sleep apnea symptoms and outcomes. So we have a lot of now, and a lot of research is now doing. So as a cardiologist, I think you have a role to also help people with improving their weight, because that would improve their, and especially when you're in preventive cardiologist. I mean, some of the interventional, of course, their role is to open a blockage, right? So this is a different focus. But I can tell you, not a lot of cardiologists are doing weight loss. Why? Because, first of all, in the past, you couldn't really help a lot of people. And cardiology is a very busy and demanding field. They don't want more things to do. And cardiology is getting paid better than weight loss. But I have this focus or passion to do this. And we see more and more cardiologists that want to treat weight loss.
Yeah.
And you will get more results and you'll get more outcome if you target it. And interestingly, a lot of patients want to target weight, because one of the challenges I have to treat cholesterol and blood pressure, because a lot of people don't like to treat blood pressure and cholesterol. For some reason, it's just like, doctor, don't worry about my cholesterol. I'm going to be fine. I don't like these medications. I don't like to be. I want natural, right? There's a lot of natural kind of bias to get something that thinking that the natural solutions are better than medications. It's not always the case. And even if the blood pressure is not great, they say, don't worry about that. I mean, it's not sexy to treat blood pressure or cholesterol, or even diabetes or prediabetes. They try to downplay it. But when it comes to weight, it's very interesting, because there's
only so much weight that you can really lose before you gain it back, right? And particularly depends on how much you weigh, right, as a patient also. Definitely. Right. Yes. So what are some of the advances and differences most recently that we've all been hearing about, from Zepbound, right?
So we definitely have game changers now, in the last decade, because we know that this is very hard, almost impossible, to take your weight from a very obese or obese category to a healthy weight. The numbers, it's very, very, it's an uphill battle, let's say. And the statistics and the data we have from research and from, and I always ask my patients, when did you see someone that was heavy, very heavy, and they read a book or went to a doctor or went to some kind of a weight loss program and just became normal weight or healthy weight for the rest of his life, for years? I don't know many that were. There are, of course, but it's a struggle. And we knew that. In obesity medicine, we knew this is very hard to have long-term weight loss solution. It's very hard, because people tend to regain the weight after months and years, right? Even in the best conducted study, so the look ahead study, you can look it up. It's a phenomenal landmark study that looked at lifestyle intervention, right?
Okay.
And they had perfect protocol, or not perfect, but great protocol. This is very expensive study, and I funded. And they had dietitians and coaches and very close intervention, and they worked and they did great. After a year, they lost kind of like 8% of the body weight, which is, I mean, it's 8%, but they were not able to really sustain it. And after 8 years of follow-up, we see that they gain most of the weight back. There is some difference. There's like 2% less than the placebo, but it's still kind of disappointing, kind of depressing that we can't just have an intervention like a lifestyle intervention that can really move the needle. And the trial tried to see if does it improve your cardiovascular risk. It was cardiovascular outcome trial, and they failed, and they didn't reach that because you need more than 8%, and you need it over time. So what you need is more than 10 and 50. We know that the number now that we like is 15%. So we really want to achieve more than 10%, even 15, and now we even have medications that can get you more, right? 20, right. 25%, and the more in the pipeline that is coming. And they are able to sustain the weight. I mean, given that you take it long term, right?
You have to take it long term. And they're safe. They're quite safe, right?
They're not safe. They're actually, the safety profile is amazing because it not only it's make you lose a lot of weight, it reduces your heart attack. And so there was a big trial. It's called SELECT trial.
Yes, I read about it in your Medscape article.
Yes. So the SELECT trial actually shows that you can lose, you can shave 20% from your risk for heart attack and stroke in high-risk population. A high-risk population with overweight and obese. And we know that you don't really need to be very obese to have this benefit, because most of the patients were just overweight or class 1 obesity, which is not the highest obesity. And most of them got, and we see the results that most of them were enrolled in the study, and we see the 20% in this population. So this is very important now. So a lot of people now asking, is now cardiologists have to treat obesity? To some extent, yes. And they're not ready yet, not every cardiologist. And there's some say, oh, we don't, we're not sure if it's in our lane. But especially the ones that, because cardiologists have a lot on their plate, right? So especially people with disease. So, but I like to do that, and definitely. So what I'm saying, there's a lot of challenges. We couldn't get this to this 10 to 15% to get the cardiovascular benefit. But now with a new class of medications, which are incretins, GLP1s, and such, we can see now really that things are changing, and they are going to change more because there are more in the pipeline that get you more than 15%, more than 20%, and some even more than 25%. And
25% of weight, right?
Of initial weight.
Initial weight. Okay. So, and in terms of, I've also seen numbers like or different types of efficacy findings, like the proportion of patients that are likely to lose, let's say, 10% of their weight.
Yes, it's categorical,
right? And they're very similar to even surgery, right?
Right.
Bariatric surgery.
So surgery outcome studies are measuring it's a little different than medical. Every I would say every field has its own outcome measurements, but we know that bariatric surgery now is the intervention with the most efficacy.
Right.
We see like 30 or 40% of the initial weight loss of the initial weight.
But like, how many patients are likely to see the benefit? Is it? Would you say?
So this is we're talking about average weight loss, right? So average weight loss, and when you take it in a trial, then you do. But there's also other measurements. It's categorical weight loss. How many achieved? How many achieved 5%? How much achieved 10%? How much achieved 20%? And you see that these numbers are getting better and better. And people. More and more people, don't forget, there are those that are low responsive, like in any medications. It's not a silver bullet for everything. And for a lot of people, unfortunately, the ones that I work with that have BMI of 40 and even higher than 40, it's even with bariatric surgery. Many of them are coming to see us after bariatric surgery, so we can help them prevent regain and improve the weight reduction if they didn't get to their goal or desired weight. So even with all those things, it's still not a slam dunk that we got rid of obesity. It's still a challenge. But my vision, and I see it, and I mean, I think that in the future, if you can tolerate and you want, and it's important to you to lose the weight, you will be able to get to a healthy weight, and whichever weight you would like to, because you will have a lot of options in terms of medications.
Now I want to kind of switch our focus towards the shortage in terms of how likely are patients to have access to these medications in the United States or
so the United States, there's a shortage. So we know that.
Let's talk about the shortage.
Yes. So I'm getting really frustrated because a lot of my patients need these medications. A lot of them have heart attack and stroke and need to prevent, and they have difficulty losing the weight, and also I want them to reduce their risk for heart attack and stroke and improve other metabolic disease. So it's very hard to get medications, and definitely in the big pharmacies like CVS, and it's just sometimes. And even if you get the medications, and I mean the SELECT trial and what is now, even Medicare is now approving it. So a lot of people get coverage, but they cannot get their hands on the medication because, and we're talking about Wegovy, right? Because Wegovy is by Novo Nordisk, and this is semaglutide, and this was proven in the SELECT trial is the only medication. We're talking about the only medication in the field of obesity that has ever passed this bar of cardiovascular prevention. We never had that before. We had a lot of risk and we had a lot of harm, and all of a sudden we have this medications and we can't get it because it's shortage. So the FDA, and we discussed that. And
the compounding. A lot of pharmacies are compounding these drugs.
So what happens? Not only GLP1s. We're talking about there are more than 100 medications that are in shortage, and if you go to your hospital, most likely they have some medications on shortage from compounded, and it's usually sourced from a 503B, which is if it's injectable, because only injectable really get like shortage. I mean, mostly but there are also pills that get shortage. But the problem is not manufacturing. The problem is something else. Maybe the generic manufacturer the medications, because it's not compound is not generic. So there are many reasons why there's shortage. There's
let's go over them in detail a little bit.
Oh, there are many. There's a supply chain. A lot of places in the supply chain that could be a problem. Some people, I mean, we have manufacturers that don't want to make the generic medication because it doesn't make sense for them financially, right? And so there's a shortage. We're talking about adrenaline. We're talking about lidocaine. We're talking about, these are not hard to manufacture. There's like generic versions of it, but we have a shortage, and there's a huge shortage. So they have to buy it from a compounding pharmacy. And you remember there was an issue with safety of compounding pharmacies back in the 2012 or 2013 with
in Massachusetts and with
the New England
CNS also, right?
They had because
Yeah.
and what they did is they created a framework and they legislated what we call the FD&C Act, which is actually giving designation to 503A and 503B pharmacies but they are giving instructions and they're giving guidelines how you should manufacture those compounded medication. And the whole idea is when there is a shortage for whatever reason it is. I mean, the shortage with GLP-1s is because the manufacturers, right, the pharmaceutical company cannot make enough.
Yeah.
They are trying. They cannot make enough because the demand is so high, right?
Right.
So even, I mean, we talk.
I think 140 million Americans qualify.
Yes, and now with the new cardiovascular indication, we're talking about millions of more patients that now are qualified, and not only qualified, but also Medicare pays for it,
are eligible.
Right? They cover it, so they're eligible and they can, so they can get it. And this is where compounding. And the problem is, and I know that.
What should the doctors know about these? Should they choose?
So the problem is there's a lot of scammers out there. There's a lot of people. You will not believe what kind of people are doing with compounded, because so you need to get the API. API is the active ingredient, right?
Mm-hmm.
The active ingredient, the FDA approved active ingredient is made by Novo Nordisk, right? So they have only they didn't give it to anyone else. But there are many manufacturers around the world, and usually they come from Asia, right? Mm-hmm. This is the big hub for API. This is where we get a lot of these. Sometimes the pharmaceutical companies source it from China, right? China is big on APIs, so they make it, and so they make the API for the compounded, but then they give it, and they come in and there's a lot of standards. You can have substandard API, and you can have very good API. It depends where you go. It's kind of, the market is the Wild West. So you can get very bad quality, and you can release it to the market. Like when you see, I'm going to give a comparison. When you can see now, you have Viagra. Viagra now is generic, but before it was generic, and because of the demand, you can find Viagra online everywhere, right? You can just order it online. You don't know what you're getting, right? You're not getting it. Now, it's the same for GLP-1s. You can get people even getting the powder with the API. They mix it at home. They give them. It's a Wild West. I heard crazy stuff they do. Plus, all sorts of venues, mostly online and social media. It's not really.
Let's educate our audience, even patients, maybe, because I mean that's one of the reasons why you wrote that article on Medscape recently.
So I really would like to caution all those people that look for, if they can get their hands on this medication and they need it for health reasons,
right?
Then it's very hard to get it online. You can't really vet them. It's not reliable.
Right.
Some people have substandard compounds, not pure, and you don't know if it's sterile. So, so I don't advise my patients to go online and source it from there, even if it's inexpensive. Right. But I do think it's responsible to use a 503B, which is a 503B. Those are outsourcing facilities that are registered by the FDA, also inspected, approved by the FDA, and inspected. So you have to understand, the material is not approved by the FDA, but it is allowed under the law when there is a shortage, right? So
which there is now, right? So we have a shortage. Okay.
So it's
many
very
of your
hard
patients will send them to those types of facilities.
No, you have to know, and you have to speak to a doctor that who understands this differentiation. And if you don't know,
and a general compounding pharmacy.
Yes, and if you don't know, I mean, you have to trust the doctor to refer you to a reliable source, and the doctors are getting educated. And there's actually an OMA Q&A publication that I looked at, and it looks really good, and it answers a lot of the questions. And of course, you need to read that. You need to get familiarized. But if a patient doesn't have my criticism sometimes I wouldn't advise to ban those solutions completely, because if you don't have access,
right.
I think getting a
Ultimately, you want as a physician, as a part, you don't just prescribe a medication or tell. You want them to ultimately enjoy the benefit and on their health from that treatment. So, which means they have to get access to it, right? So, you're providing them different solutions, and I take it you've done the research. And
I'm still learning, and I'm getting. But I would.
Are you getting successful results from some of these facilities, Dr. Einav?
I mean, in most cases, I can get the brand name. So in most cases, I don't need to use it. But
you don't need.
If I had to use it, if I don't get consistent supply for the patient, and I do inform the patients that they have a choice, and they can get the compounded one. But I would only refer him to a source that comes from this 503B, and I'm sure this is a reliable source. I will not just send him online on his own. And there are a few reliable sources that 503B that are very good, and are used by hospitals and everywhere. But I'm telling you, part of the fuss now that is, you see it all on the news, compound medications, terrible. I can tell you there are scores of medications that are compounded, they are not FDA approved, used by hospitals, and people don't make a fuss. Why? And it is not a lot of money, but because of the GLP-1s is backed by big pharma, that some of their worth is more than GDPs of countries. So of course, and a lot of doctors get their information from those pharmaceutical companies, because they control the agenda. But I can tell you, the same sources, the same 503B are giving your hospital lidocaine and adrenaline, and people and doctors are not even aware they're giving it to them, because the doctors. But now with GLP-1s, it's a big deal. I think it's a little bit double standard that we say don't use compounded if it's GLP-1s, but you can use compounded for adrenaline or for any other thing. If you think the GLP-1s are important for your health, we're not talking about, getting into a dress. If it's really someone had a heart attack, you need it, and you need it like you need lidocaine, like you need chemotherapy, like you need antibiotics. So you give it. You should have the same standard for GLP-1s as you have for other medications. You can't have different standards.
So your point well taken. Yeah, very strong point you're making, I think. And I want, people to
and a lot of obesity medicine doctors are not aware that these compounded medications are everywhere in the hospital, everywhere. They're only aware of the GLP-1s. Why? Because it is an agenda pushed by pharmaceutical company. And
just to take kind of the different kind of perspective, there are quite a lot of them that do not have high quality that they adhere to, which you also mentioned. So it takes some education, right?
Yes.
So somebody like you as a leader and in our healthcare community should probably educate the other physicians where to go. What are these facilities?
But the same way, you're not going to get Viagra online, right? You're not just getting. You're going to go to a pharmacy, and a reliable, reputable pharmacy. The same with GLP-1s, right? You need to go to a reliable source. And
so where can people learn more about these options, the reliable, some of these facilities that use these APIs, but that have been already inspected by the FDA? Is there? What would you like to leave our patients?
There's a lot of levels of quality you can look for, and a lot of them are in publications, and the OMA has composed
so the Obesity Medicine Association, for those of you.
A Q&A and the Obesity Pillars, they have a publication, and I think it's a good source. I think it's a good source for people who want to use those compounded medications, but they are concerned about the safety of and how to vet a source.
Right. That's what I want.
It should always be a second line of treatment. Let's be sure. I mean, of course, if we didn't have shortage, we wouldn't be talking about it. So it's just because of the shortage. And unfortunately, it's because of the cost. A lot of people go to the compounded because it's less expensive. But it's not supposed to answer the expense part. Although, I advocate for my patients. So if someone had heart attack and stroke, they cannot get their hands on this medication. I'm not going to give them phentermine if he had a heart attack. Sorry. And I'm not going to give them Qsenia or other. I want to give them GLP1s, right? I want to give them semaglutide to cut down the risk for heart attack.
I think one of the challenges also that I would pose is that perhaps this is more of a preventive treatment where an obese patient may not really feel that they're sick necessarily. They're used to their lifestyle. Okay, they have a little bit of extra pounds on them, but it's not like cancer that you have to treat with chemotherapy or lidocaine for pain or various different acute conditions, right? So perhaps that's what contributes.
Well, I don't know if that is the only difference between this type of compounded. I think the big difference this is the only, or to my knowledge, is the only medication that is not generic that ends in shortage.
Oh, okay. I see what you mean.
And I think and it's a blockbuster. Right. It's everybody wants it, right?
Right, everyone.
It's a blockbuster. So you have a blockbuster, and you have it such in high cost, and all of a sudden it's in shortage.
It's prohibitive.
So compounding is getting, and this is why a lot of I would say bad players are coming, and it's a mess. I agree with that. I agree that this is a challenge, but the answer is not to say don't touch it.
Right. That's the point we want to make.
The solution is to help people differentiate between good players and bad players. I mean, otherwise you deny them of the solution, and you make the solution even worse because you let the market define who's better and who's not. And you don't. I mean, me as a doctor, you have a leadership role. You have to help the patients, right? You don't just say don't get near. It's not, and you just this is no solution. You need to say if you do need to use it, this is how to use it.
Right.
This is our role because people will use it. People are using it. Even they're estimating like 30% of people with obesity looking for GLP-1s are looking for compounded, are using compounded.
Oh, interesting statistics there. Okay, so 30% of those.
I mean, that's the estimate I read in some of the publications. It's only an estimate, but it's clearly
there's clearly a market for there's a shortage, of course. Yeah,
huge market.
Okay, so just in the last few minutes here, just a minute or two, I'd like to just ask you to wrap up and just provide a message. How can people contact you, those who are concerned about their weight management, if they want to address their condition, and what you want to leave our patients and providers and public with today, with this discussion?
So I want to address mostly the people with high risk, people with cardiovascular disease, people who already have cardiovascular concerns. They either had a heart attack or a stroke or have atrial fibrillation or have some cardiovascular weight-related disease. We have a solution. We have now multiple treatments that can improve your outcome. And why won't you want to use that? I mean, we're talking about, like diseases like stroke and heart attack. You don't want to have stroke, right? You don't want to have stroke. It's going to impact your life tremendously. And this is, if I now offer you 20% off, I mean, I would not leave it on the table. And of course, with the other diseases. So now we have a field of cardiometabolic medicine, and I'm kind of involved in this field. I'm part of all sorts of organizations that are promoting this because we saw that this is very fragmented. One person is doing blood pressure, the other one is doing sugar, the other one is doing lipids. So this is why we want to promote the cardiometabolic, and has weight and all those other issues that I discussed, all the risk factors, including inflammation, and I think this is an exciting time, and you can reach me or a lot of my colleagues that are invested in this type of cardiometabolic medicine, that you not only lose a lot of weight, and we're talking about people that have health concerns, weight concerns, or overweight or obesity, but you can also improve so many other risk factors, and directly your risk for heart attack and stroke and disease also. So heart failure, we know now that we have great outcomes. There's one from Eli Lilly that's supposed to come in the future. They already announced the result.
Yeah, the data, right? Yeah, I think 60% of the patients had 10% reduction, or right?
No, that was not what they did. Initially they had one CHF publications for that. So if you had a heart attack, had a stroke, or you have heart failure or atrial fibrillation or other cardiovascular disease, you should consult people with knowledge and focus on cardiometabolic health. You can also reach me directly on my website, or just Google me.
And what is the website? What is the website?
The website is My Weight. It's spelled
My Weight.
myw8.com.
myw8. Okay.
Yeah, that's kind of a catchy name, but the legal name is Cardiometabolic Health, and by my name, and you can reach me, and I can answer your questions, and I can see you, and I can direct preventive. And even if you have cardiac disease, I can address cardiac disease and your cardiometabolic risk.
Great. Well, thank you very much for your time, Dr. Einav.
Thank you.
And I know that we're going to have more conversations. This is only part one, I think. Great. So we have a tremendous leader, expert, educator here, Dr. Einav, also Obesity Medicine Association and myw8. Please connect. My Weight. Yeah, My Weight. Make sure to contact Dr. Einav.
Thank you, Tim. Thank you so much.
Thank you.
Okay.